Hello, everyone, and welcome to the IBD Insider Patient Updates from the Crohn's and Colitis Congress Inflammatory Bowel Disease IBD A to Z program, what every patient needs to know. This IBD Insider Patient Program is supported by a sponsorship from Bristol Myers Squibb. Today's presenters include Dr. Rajeev Jain. He is a partner for Texas Digestive Disease Consultants, Chief of Gastroenterology at Texas Health Dallas, and Patient Medical Education Advisor for the AGA. Jami Kinnucan is Assistant Professor of Medicine at the Division of Gastroenterology and Hepatology, Department of Internal Medicine at Michigan Medicine, University of Michigan. She is Patient Education Committee Chair for the Crohn's and Colitis Foundation. I am proud to turn the program over to Dr. Jain.
Thank you. On behalf of Dr. Kinnucan and our sponsors, we appreciate you taking time out of your day to watch this important program. Our objectives today are to define inflammatory bowel disease, its potential causes and diagnoses, to discuss management and treatment, to discuss complementary medicine, as well as reviewing the role of diet and nutrition in inflammatory bowel disease. Next slide. Inflammatory bowel disease, or IBD, are disorders that cause inflammation in the gastrointestinal tract. Crohn's disease and ulcerative colitis are the two most common forms of inflammatory bowel disease, which affects almost 3 million Americans. The symptoms and course of disease can vary from one person to the next. The potential factors to consider are shown on this Venn diagram, and there's many overlapping factors. One is genetic factors. Some patients harbor genes that put them at higher risk. For example, patients of Ashkenazi Jewish ancestry have some genetic factors that increase the risk of small bowel Crohn's disease. Additionally, some patients, because of what we call the gut microbiota, the billions of organisms that reside in your gut, mostly in the colon, alterations in that can perhaps increase the risk of developing inflammatory bowel disease. A third factor could be immune system abnormalities. As we know, this is a disorder where the body attacks itself. So some alteration in that may increase the risk of developing inflammatory bowel disease. And then finally, there probably is some environmental exposure or trigger that starts this disease process. So let's talk about Crohn's disease and ulcerative colitis, perhaps compare and contrast them. So in Crohn's disease, you can have inflammation occur anywhere from the mouth to the anus, but most of the time it occurs in the last portion of the small intestine and or the beginning of the colon. Typically, the age of onset is somewhere between the ages of 15 to 35 years, and that's the main peak. There is a second smaller peak later in life between the ages of 55 and 70. But again, both Crohn's and ulcerative colitis can be diagnosed at any age. The symptoms in Crohn's disease really depend on the location of the disease and can include primarily abdominal pain, diarrhea, weight loss, and fatigue. Bloody stool is more variable in comparison to ulcerative colitis, and malnutrition is much more common in Crohn's disease because of the small intestinal involvement. Now, to contrast that a bit with ulcerative colitis, by definition, it involves the colon beginning in the rectum and is continuous, whereas Crohn's disease can be patchy. Again, much like Crohn's disease, the age of onset, there's a peak in the late teens to early 20s to 30s, and then a second smaller peak later in life. The symptoms tend to be related to the area of involvement, that is the colon and the rectum. So you tend to see more symptoms of stool urgency, frequency and diarrhea, mucus in the stool, blood, and even nocturnal bowel movements and abdominal pain. Bloody stool is much more common and malnutrition less common in ulcerative colitis in comparison to Crohn's. Next slide. In terms of the diagnostic process, it really includes many steps because both of these disorders, there's no one simple test that makes the diagnosis. It's a syndrome, really. So an important part is taking a good medical history and physical examination from the provider. This will ultimately often lead to diagnostic testing that will include blood and stool tests, perhaps radiology examinations, and endoscopy and colonoscopy with biopsies. Then that leads us to think that, hey, this symptom complex and findings are consistent with either Crohn's disease or ulcerative colitis. There is a group that is in between, and we call that indeterminate colitis. And finally, there are many other disorders that can mimic inflammatory bowel disease, and that may lead us to another diagnosis. Next slide. What we need to recognize are symptoms of inflammatory bowel disease flares. Some of the most common symptoms include diarrhea, a change in movement or frequency, a sense of urgency where one feels as if they only have a few seconds to minutes to get to the restroom before losing control of the bowel movement, and often rectal bleeding, cramping, and even mucus in the stool. One, as this is a systemic disorder, can experience low-grade fever, and with any inflammatory condition, one can feel fatigue and tiredness. Next slide. So in understanding the complications of Crohn's disease, an important concept to remember in comparison to ulcerative colitis is that Crohn's disease involves inflammation of the entire wall of the bowel. So as this inflammation occurs, it can cause narrowing or an intestinal obstruction in the small intestine or even in the colon. Because it involves the entire wall, it can cause leakage and a pus pocket forming called an abscess. And that connection between the gut and another organ or to the skin is called a fistula. And that's another manifestation of inflammation throughout the wall. As I mentioned earlier, you can develop a stricture, which is a narrowing from active inflammation or from scar tissue because of repeated bouts of inflammation. And then finally, because of chronic inflammation that can lead to changes in the lining of the colon, there is an increased risk of colon cancer for those patients who have Crohn's disease involving the colon. Next slide. In terms of understanding the complications of ulcerative colitis, because of the inflammation is mostly involving that last layer on the inside of the colon, you can have anemia from the inflammation and blood loss. In some cases, the inflammation can become so severe and the colon can become dilated that one can suffer a perforation. And that's, those symptoms are quite significant. And then finally, just like in Crohn's disease of the colon, the chronic inflammation, more of the colon being involved in the duration of the disease, all increase the risk of development of colorectal cancer. Next slide. Both disorders are associated with what we call extraintestinal manifestations. That is, the disease can lead to other parts of the body having changes. So for example, in both disorders, you can develop arthritis. And some arthritises are more peripheral, that is involving your hands and knees and ankles, whereas some can be more axial, that is involving your spine and pelvis. The kidneys can be involved with inflammation, kidney stones developing because of changes in metabolism and surgeries. Liver disease, particularly primary sclerosing cholangitis. This is an autoimmune disorder where there's inflammation in the bile duct, which can then lead to jaundice, even increased risk of bile duct cancers and liver failure. A very common side effect that's seen in the mouth is called aphthous ulcers, which are little sores, and that tends to mimic disease activity in the gut. In the eyes, one can get the whites of the eyes turning red. That's called iritis or episcleritis, and that again tends to go along with disease activity in the bowel. And then finally, a common complication are skin manifestations. One common one is called erythema nodosum, which is sort of a red whelp that tends to occur in the lower extremities. Some more serious complications, such as pyoderma gangrenosum, are a serious involvement in the skin, which requires assistance often from our dermatology colleagues. Next slide. At this moment, I will hand it off to my colleague, Dr. Kinnucan.
Thank you, Dr. Jain. That was an excellent overview on the basics of inflammatory bowel disease and what patients should expect in terms of symptoms, diagnosis. And now I'm going to get us into the management and treatment of inflammatory bowel disease. So overall, we have to look at what our goals are in terms of evaluating treatment with inflammatory bowel disease. Patients want to feel better, and providers want patients to feel better. And we have to do this by inducing a remission stage. This is a stage of healing. And what this means is that sometimes we require using steroids to get into this remission stage, but the maintenance of remission, maintaining this healed stage, is the absence of steroids and using a steroid-sparing medical therapy. So inducing remission means that we can get you feeling well. Maintaining remission means that we can keep you feeling well. To do this, we need disease monitoring and prevention, and overall with the goals that we both have, which is improving quality of life, being able to go to school or go to work or attend functions and not worry about where a restroom might be or not worried about how foods particularly will impact your day-to-day functioning. There are many factors that influence our ability to control inflammatory bowel disease. These are patient-related factors, patient's weight or BMI, whether they're male or female, their underlying nutritional status, pharmacogenomics, how well your body responds to certain therapies, adherence to therapies. One of the more common reasons that patients may not be or maintain remission is because they've spaced out medications or they've lacked adherence to medical therapies. Smoking is a big factor that can play a role, especially in patients with Crohn's disease, in our inability to get the disease under control. And of course, mental health and feeling well is just as important as your body doing well and controlling inflammation. There are several disease factors that are out of patient factors control. So the lag time before diagnosis, the importance of, if you have symptoms, getting to your healthcare provider and diagnosing the presence of inflammation as a possible cause to your symptoms. The phenotype of your disease, whether your disease has complications like Dr. Jain had talked about, strictures or an abscess, or if this is just truly inflammatory disease. The presence of the genotype or the microbiome that you have. Dr. Jain alluded to the microbiome, and that very much plays a role in our ability to control disease. Various immunology factors about the disease, as well as your immune response through C-reactive protein. There are also various therapy factors that are important to consider too, whether or not you've had resections, previous therapies you've been exposed to and have not been successful in terms of treating your inflammation, the presence of steroids or a history of steroid use. Some of our medications have a dose response. Some medications have a shorter half-life and some have a longer half-life. And of course, even more important in therapy factors is the route at which we give you these therapies. Some therapies work better with certain patient factors than other therapies. Next slide. So understanding our treatment options, this is going to take a very high-level overview so that you understand what we have in our IBD toolbox to treat inflammatory bowel disease. We can use over-the-counter medications, which are really great to treat non-inflammatory related symptoms. So we know that over-the-counter medications don't work in treating the disease inflammation, but they can make you feel better. There are prescription medications that can be prescribed by your healthcare provider. Surgery is very much a part of how we manage certain types of inflammatory bowel disease. And then complementary and alternative therapies, I think, are important to address in this as well. Next slide. So over-the-counter medications that you may be using are antidiarrheal agents for patients who have ongoing diarrhea, laxatives for patients that might be more on the constipated side, and then of course, if you have pain, various pain medications. Common antidiarrheal medications that we use come in the form of Lomotil or Imodium, which can be taken as needed or scheduled depending on how they're prescribed by your healthcare provider. While these are over-the-counter medications, sometimes we do provide prescriptions so that they're covered by insurance. Some patients that have fevers or various pain associated with their disease, including joint pains, as Dr. Jain had alluded to, which might be an extraintestinal manifestation of your inflammatory bowel disease. You can use Tylenol, which is preferred, or acetaminophen, over using NSAID therapies like ibuprofen or Aleve or naproxen, which may actually irritate and worsen GI inflammation. What's not listed on this slide is the use of narcotics. We try to avoid the use of narcotics in patients when able, as we know that long-term use of narcotics can be associated with worse outcomes in our IBD patients. Next slide. This is a really great overview slide of all the medical therapies that we can prescribe for you for your inflammatory bowel disease. Some patients with Crohn's disease and patients that may have undergone a J pouch surgery or patients that have bacterial overgrowth in their small intestine may benefit from the use of various antibiotics. Aminosalicylates, these are medications that are mesalamine-based therapies. Sulfasalazine might be another thing that you recognize. There's various formulations of these that come in either oral or topical per rectal therapy, are really good and have been shown to be effective in mild to moderate ulcerative colitis and probably have a very limited role in patients with Crohn's disease. Corticosteroids are very helpful to achieve a remission stage, but have no role in the maintenance of remission in patients with inflammatory bowel disease. Our goals as providers and your goal as a patient is to find a steroid-sparing therapy, one that allows you to get off steroids, because we know that steroids, especially in the pandemic, have been associated with worse outcomes for patients and have been associated with an increased risk of poor outcomes associated with COVID-19. Immunomodulator therapies, which modulate the immune system, can come in both oral and injection-based formulation. These are things like Imuran, azathioprine, methotrexate, or 6-mercaptopurine. Biologic therapies, which are large protein-based therapies, are the therapies that we give by infusion or injection. We currently have 3 classes of biologics, including anti-TNF therapies, anti-integrin therapies, and anti-IL-12/23 therapies. And lastly, the most recently approved therapy class are the JAK inhibitors. Currently, we have one therapy within this class, tofacitinib, that has been approved by the FDA to be used in patients with ulcerative colitis. Next slide. It's important to know that we also consider diet and complementary medicine when we think about how do we manage patients with inflammatory bowel disease who have persistence of symptoms. Next slide. What is complementary medicine? Well, this is classically thought of as non-mainstream practice that's used together. So always used together with conventional medicine, some of those prescription-based therapies and maybe over-the-counter therapies that we talked about. We know that our patients are using complementary medicine when we ask them. About 21 to 60%, depending on the studies that you look at, have used complementary therapies or are actively using complementary therapies to improve their pain, to help control their symptoms, to contribute to a better quality of life, and help improve their mood and overall general well-being. On the next slide, I'll talk to you about some of the more common complementary therapies. Next slide. Which include mind and body therapies like yoga, vitamins, minerals, and supplements, various probiotics or microorganisms, things like prebiotics. And then medical cannabis often comes up as one of the more recent common uses of complementary therapy in inflammatory bowel disease. Next slide. What I have to caution you on is that we still don't know a lot about how do we best use complementary therapies in conjunction with our medical therapies in inflammatory bowel disease. There is research underway to study the benefits of treating inflammatory bowel disease with these therapies, but as adjuvant therapies, meaning being used together. There are no studies looking at complementary therapies as a replacement to conventional medical therapy. We have to caution that most, if not all of these therapies are not regulated by the FDA. And so they have not had robust studies, and thus they're not regulated or controlled or followed up for safety data. It's important to seek out that good data to minimize your potential risk with taking complementary therapies or practices. They should, again, complement and never replace conventional medical therapy. And you should always involve your healthcare team in the decision to add complementary therapies to your medical practice. On the same note, it's important that we also understand the role of diet and nutrition in managing inflammatory bowel disease, or even just in the day-to-day functioning of patients with inflammatory bowel disease. Patients with small intestine inflammation have problems digesting food and absorbing certain nutrients depending on where their inflammation is located. Patients with large intestinal inflammation have problems absorbing water and electrolytes due to ongoing issues with diarrhea. And we know that various symptoms can lead to issues with malnutrition. Pain and nausea may contribute to your lack of desire to eat, and so you reduce your intake and ultimately reduce your nutrition. Severe diarrhea can lead to dehydration and may require a visit to the emergency room, hospitalization, or outpatient fluid management. And we know that ongoing issues with either overt bleeding, where we can see the blood in the stool, or even microscopic bleeding, where we may not be able to see the blood, can lead to iron deficiencies and anemias in our patients. It's important that you should recognize signs of malnutrition, and that your healthcare provider, when they see you, should also be screening you for malnutrition. Even mild cases of malnutrition can make it more difficult for your body to bounce back after you have a relapse of your disease. Some of these signs of malnutrition can include undereating or severely restricting some of the food intake that you have, because overall you feel better when you don't eat certain foods, in the absence of working with a dietitian. Weight loss can be a first sign of issues with malnutrition. Generalized fatigue or low energy level, the presence of diffuse weakness or loss of muscle mass, and the presence of vitamin and mineral deficiencies. It's important to note that even patients that have a higher BMI and are considered obese are still at risk for malnutrition. So it's important that you work with your healthcare provider to not only screen you for malnutrition, but making sure that you're having your vitamin and your mineral levels checked. There are some strategies to help maintain healthy nutrition. One idea is to create a food journal and consider eliminating some foods that create more symptoms for you. However, I caution my patients to never eliminate foods without working closely with a dietitian or a nutritionist to ensure that you don't restrict too much and result in vitamin mineral deficiencies or any malnutrition. It's important to strive for a well-balanced, healthy diet that you focus on hydration, nutrient-rich foods, small but frequent meals, and simple cooking techniques. Again, when we try to incorporate these into your management of inflammatory bowel disease, it's important to partner with your healthcare provider or your team and consider working closely with a dietitian or nutritionist if there's concerns about malnutrition. Next slide. That's the end of our IBD A to Z program today. I wanted to thank you for joining Dr. Jain and I today to review some of the basics surrounding inflammatory bowel disease. We have a really exciting program coming up through IBD Insider, which if you're watching this before January 30th, you may be able to watch live on January 30th at 12 p.m. Eastern. Don't worry, if you're not able to get on live for the IBD Insider on January 30th, we will be recording the session, and it'll be available after use. We are going to be touching on some very important topics about how to get the most out of your healthcare visit, how to manage inflammatory bowel disease during COVID-19, and looking at various changes or any upcoming changes to medical management of inflammatory bowel disease. We really hope that you can join us on January 30th, or at least watch us after the fact. Thank you so much for your time.